None of the content on this or any episode of the Kratom Science Podcast, Kratom Science Journal Club, or on any page of KratomScience.com is intended, nor should it be considered, medical claims or medical advice. This is the Kratom Science Podcast. I'm your host, Brian Gallagher, blog and social media writer for KratomScience.com. Your source for all things Kratom. Dr. Kirsten Smith from Nida returns to talk about her research since we last spoke in 2021 on Kratom dependence, consumer characteristics, a study on Reddit posts, the limitations of case reports, a Kratom guide for healthcare providers, and a new nationwide assessment you can participate in as a Kratom consumer. I wanted to talk about the Ecological Momentary Assessment study with product assay first. It'll be a new survey followed by some more comprehensive study. So what is that anyway, Ecological Momentary Assessment?
Yeah, so it's a mouthful, and I should warn everyone, since I have their attention for a moment, that this should not be considered another survey. So there is a survey component, and the reason for that is because we need to get the kind of information that can only be got on a survey. So tell us about when you first started using Kratom, and this more detailed history, demographics, just stuff that people are kind of used to seeing on a survey, and it takes probably an hour and a half to complete. That's all fine and well, but that's kind of just the tip of the iceberg to what is a ultimately about 2.5 week long study. And what's going to happen is that once all of the materials are approved, which should be soon, which just in the next couple of weeks, we're going to start recruiting people. So it's a national study that NIDA Intramural Research Program is doing. And it's enrolling regular Kratom using adults in the United States. And I can't give more than that away, because otherwise people could game the system and say, oh, I meet eligibility criteria when I don't. But that's the gist of it. So if you are a regular Kratom using person in the United States and you're an adult, you can take our screening questionnaire online. It takes not probably 5 minutes. Real short. And if you're eligible, then you're prompted to complete kind of this informed consent quiz. Because it's a 2-week long study, we want people to understand fully what they're getting involved with. We talk about the ecological momentary assessment more, which I'll give everyone a brief nutshell version of right now. And then once people say, okay, I think I can do this, I think I want to do it, it is compensated. We can't pay a tremendous amount because we only have so much money, but we do try to compensate people for their time. And then, people, we hope, will do it out of the spirit of wanting to advance the science on Kratom. So once people decide that they want to do it, they're interested, they think that it's not going to be this horrible time commitment that they can't really follow through on, then we, give them the survey. After they do the survey, they have 2 days to download our study app. And it's a secure app. You don't even have to put any identifying information in there. And once that app is on your smartphone, then instead of asking a long survey like we do at the beginning and has been done with a lot of Kratom studies in the United States so far, what we do is called momentary sampling. And so what we do is we hit people up at different times of day. 2 of the times of day are set kind of like a diary, an electronic diary is what we call it. So there's the beginning of day and the end of day. And that appears for about an hour and a half around whatever it is your bedtime and wake time is. So if you tell me that you get up at 6:30 every day, then we make that beginning of day available for about an hour and a half for 2 hours right before and after you wake. And you just answer eight questions. And at the end of day, same thing. Around your bedtime, you answer 6 to 10 questions. I forget exactly how many we ask at each time. And then in the middle, during your waking hours, as you're going about your normal life, we do what's called random prompts. So we'll give you a little notification, kind of like a text message, and you have about a half an hour to respond to it. And it's very short. It's not supposed to be this big burden, because if it was a huge burden, people would just say, I'm not doing it. And we ask you, how are you feeling? Are you in pain? What's your anxiety level? When's the last time you took Kratom? And then in addition to that, we have what are called, the jargon is event contingent prompts. But really what that is anytime you use Kratom, you just report it into the little app and just you say, well, how much did you take? Was it powder? Was it in capsule form? Was it toss and wash? Was it an extract? How much did you take? And then we ask, what was your motivation for using? Because you and your audience know this better than anyone else. The reasons that people take Kratom are varied, right? Like, so someone could have 5 big overarching reasons for taking Kratom in general. Like in general, I take it for pain because I want to relax. I want to help, I want to help my sleep, stuff like that. But it could be, or anxiety, but it could be that on one day your pain level is really high or your anxiety level is really high. And so you might use more Kratom, or on another day it's less and you use less. So there's no like wrong answer or anything. You just kind of like let us know what's going on. And you do this for 2 weeks. And at the very end of that 2-week reporting period with the smartphone app, after that, we ask that I should say kind of at the midway point, we ask that you send in a small sample of the Kratom product that you're taking most often. And we provide all the shipping materials. No one has to pay for anything. Nobody's name is on anything. We put our return address so that no one will know that like John Doe in Tupelo, Mississippi is not a good example, but anywhere, New York City, doesn't matter where, that there's nothing identifying about you on there. So we are very, 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 very serious about privacy, confidentiality, using your data only for scientific purposes. And that's really the gist of the study, but it's going to be exciting because we'll be able to characterize the alkaloid content of the Kratom products that people send us. And so we can hopefully see, how much mitragynine is in this product, and maybe that it's going to be very crude, but maybe we can correlate that with their self-report during the time they were using this product and see that, this product with higher levels of mitragynine actually ended up being more potent for them in terms of subjective self-report. And that's something we're really excited about doing. So that is the very short version of the study. And when we have our landing page up, people can go to the Nida Kratom study landing page and there'll be a little button, click to see if you qualify. Believe me, I'm going to pester you to tell people about it as soon as it's live.
Oh, I definitely will.
And tweet about it because we're really, really excited. We're kind of nervous because no one's done a national Kratom study that isn't a survey before. So we're kind of freaked out. And we're excited, but we're like, what's going to happen?
Yeah. This is really big. In terms of regular users, do you qualify? I know one of the studies I was looking at, it was like 4 or more times a week that you use Kratom. Is that the qualification?
So that's one thing I won't tell people because if I do, so I'm not saying you or any of your listeners would do this, but some people would be like, I'm really close to this. I'll just say that I use this amount per week and get in the study. So that's the one thing I won't say. We'll just ask that people, when they do the screening, that they report accurately, how many times per week or how many days per week do they use? We have to keep that part secret.
And is there a component, because this is the last thing we talked about on the last podcast, you guys were in the planning stages, but is there like a component where the participants give like blood samples or urine samples to see like medically how they're doing?
For a very special select few, we are going to be doing a local in-person component. And so likely this will be people who we're located in Baltimore City. That's where the NIDA IRP labs are. And so if you live in or around that area and you see that you qualify for the study, then what our group will do is reach out to you and say, hey, we noticed that you live kind of in the area. And of course, people are welcome to travel to come do that in-person component, but we don't expect people to travel for the study because that would be a burden on them and we can't pay for it necessarily. So if you're in the area and you qualify, of course, for the study, you could be invited to do the in-person component. So if you're eligible for that, it means you will have completed all of the stuff I already talked about, but then you'd come in for a study session day. And so that study session day would actually involve taking your Kratom product and then being observed by nurses, our research nurses and study team, and then doing a whole lot of questions. So not survey questions, but more like real time, like psychomotor assessment, how you feel basically. So the subjective feelings that you're having, the effects you are receiving, and then we'll take a blood sample, urine sample, and another sample of the Kratom product that the person has taken there. So all of those will be analyzed. We can't do, unfortunately, because this is like a baby starting point. This is not going to be a PK, like a pharmacokinetic study of the scale that I hope to do very shortly after this, but it is a starting point for just seeing, what metabolites show up in urine and what alkaloids can be detected in plasma, and then, of course, in the Kratom product. So yeah, there will be that component, and there will actually be a driving simulation component too that we were able to hustle up. So it's going to be a full day. Yeah, and then
that's cool.
Yeah, it's really neat. And then a qualitative interview at the end, because something that, is really frustrating to me is that, I'm coding Reddit data again for the second Reddit paper. And some of the stories that people tell, they don't make it to the scientific literature. And therefore, I know they exist, but we can't capture them in depth. And so for the 10 people that come in tonight to do the in-person component, I'm going to sit down and personally interview them and get what's called just a narrative case history and let them tell their story of how they started using Kratom and how it changed over time, or if it changed over time, and write it up as a case report series. Because we can talk about this later, we have a lot of clinical case reports, but they're fairly problematic in how they report information. So
I mean, you said it was like a baby study, but this is like the first time anything of its kind has gone on, right? I mean, most of them have just been surveys and just like looking over online data. I'm excited to see this, and I hope people consider participating in it. I know Nida just recently updated their Kratom page, which they tweeted out yesterday, and I saw, so I think everybody should look at that, and I think it's like pretty good data, and it's good to see. Okay, so what about this case report? It's a systematic review. A lot of the case reports, and I was actually talking about it with my last guest, Morgan Godwin, who's a writer who was incarcerated. She was a former heroin user, and she was incarcerated, and she recently wrote an article about her Kratom use, and she was talking about how she did her own research about Kratom, and she was looking at case reports. What she said is you don't go into a doctor's office or the ER and say, oh, well, that Kratom just cut my pain in half, because why would you do that? You're going to go to the doctor to say something's wrong. Is that part of maybe what's wrong with some of the case reports?
I'll answer this in two ways. And the first way to say, or the first thing I'll say is that the case reports, just by their nature, they skew towards extreme and more negative cases, because that's kind of what gets published. And so some of the online surveys, I would say, probably skew a little positive, just because, it's people who are mostly regularly using. And if they're regularly using, they probably don't hate Kratom. They might skew positive. And that's what we call self-selection bias. And it's just something you got to own. With the case reports, there's a tendency, if you're a physician or just a clinician of any kind, you're not going to write up a boring case report or, well, the patient presented and had, reported Kratom use and nothing was going on. That's not going to be published. So there's absolutely no way of knowing how many adaptive Kratom use, case reports could have been written but weren't. So just from the beginning, the way the system of publishing works is going to already be a little bit wonky in terms of more extreme things being written up and then more likely to be published. But beyond that, I think what we're seeing in doing what's called a systematic review, which is very rigorous. There's a protocol for how you review all of these different case reports. So we're not just sitting there, with no, aimlessly reading them and thinking, that's okay. No, it's like there's a checklist of how we even include them. And when that comes out, I'll send it to you. But what we're seeing is that oftentimes clinicians are not accurately they're not assessing or diagnosing in any sort of systematic way. A really, really good example of this is when you see like Kratom addiction or Kratom abuse or Kratom misuse, or even kratom use disorder being used, but there's no indication that any diagnostic criteria were applied in the assessment. And so there are terms that are actual clinical terms that are not being used accurately, or if there was some sort of assessment and diagnostic process that was used, authors are not reporting it. So that's a really big one for me that kind of irritates me. But I think the other issue is just dosing and the variability of kratom. So a lot of these case reports are written by people who don't necessarily know what kratom is, or they encounter a patient using kratom and they Google it, and who knows what they're going to find when they Google it. And then with not a lot of understanding about it, will then write up a case report with very little knowledge about it and then fail to include a lot of relevant or important information, or not ask the questions that we need to draw any meaningful conclusions from. So for instance, dosing, but how much were you dosing per day and of what specific type of kratom? So you can say grams per day, but grams of what? What I would also say is problematic are just dose amounts being reported that exceed what we would believe to be possible. And I say that with full awareness of people dosing in high-end cases of over 90 grams per day, or what could be converted to that if they're using an extract. But so we're just missing information. And to your other part of your question, what we did ask on a survey recently, which the findings will be coming out literally within like a week or two, it's been accepted. It's just not quite out yet. And we asked people, did you try kratom because of barriers accessing adequate treatment for mental health, for substance use disorder, for pain, for general health? And we asked people how comfortable they'd be. And interestingly enough, over half of the sample said that they would either be comfortable reporting it to a healthcare professional, or they really wouldn't think about it too much one way or another. Now, it wasn't everybody, but it was over 50%, which I was surprised by.
Yeah.
However, but these treatment barriers were listed as very specific reasons for trying kratom.
Yeah, I wanted to talk about that too, but more on the case reports. It's like, and by the way, I want them to report if somebody had a bad reaction to it, but I was doing one specifically on liver toxicity, and I'm looking at every single case report, and every single one, it's like the person might have also had fatty liver disease, not known about it. That's something that presents without symptoms. There was one that we looked at on the Journal Club it was called Kratom-Induced Psychosis. It's like they're kind of quick to put kratom in the title, and this guy who had a psychotic episode was awake for a week because he quit all other drugs, including hormones and pills that would, if you quit, might give you insomnia on your own or cause all kinds of issues. And he happened to have been taking not that much kratom, I don't think. Although, like you said, there's a difference between extracts and plain leaf kratom. Do you think there's like a motivation to put kratom in the title because it's a new and unknown thing and that helps with publishing, or is that something you'd even care to speak about? Or
so I won't speak to any specific motivation paper or author because who knows what's in people's hearts and minds and intentions. And I'd like to extend the principle of charity to most people most of the time. That said, I think so one thing that is across the board understood is that case reports, and I was talking with Dr. Stephanie Weiss, our medical doctor, who's also a toxicologist and addiction MD as well, who is very familiar with kratom and has treated patients that have become dependent on kratom. And we were talking about the case reports, they're one of the weakest forms of evidence, right? Because the person, A, there's such little information, and B, we cannot even begin to ascribe causality when there are so many factors, let alone so many unknown factors. So anytime that you see anybody asserting causality, whether it's a case report or anything else, it's very, very, very difficult to prove that A is causing B. And usually, even when A is causing B, there's about 20 other things also influencing how A causes B. So it's just to be treated as one kind of information potentially. And again, I'm like you, I want to see more case reports. I was at a conference, American Society of Addiction Medicine, and we spoke to a room full of 90 clinicians, all of whom had interacted with patients who had some kratom use or kratom withdrawal or kratom dependence. And I told them, write up case reports, but please do it in the most accurate and specific way possible, because we really have a dearth of good case reports. And I would say that in some cases, people probably are publishing with any hot topic or quasi hot topic. There's a motivation to publish because it might be easy, but that's not good. No one should do that.
I want to find out, because then I can take this to my podcast and say, hey, everybody, if you haven't slept in a week, maybe you shouldn't do kratom, or, it's kind of like safety things that I really wish I could, say, look, here's where you're going to get into trouble with how much kratom you're taking every day, or just like a guideline, because I just kind of think it's the responsibility of the side that wants to keep kratom legal to be honest about the safety issues. It would be great if everybody would be comfortable about talking to their doctor. And so that gets into the other thing that was published that I was pretty excited about, which was the Guide for Healthcare Providers. You and Mark Swager and a few others. So why did you decide to do this? And because I know I've been telling people, tell your doctor, because they should know that you're healthy and doing kratom. But then I was in an argument with a guy on Reddit, and he said, that's a bad idea, because if somebody has a past history of drug use, your doctor's he's afraid they would put him on some list of somebody who uses drugs, and maybe they won't be able to get pain medication. Just what were your reasons for putting that together?
Yeah, I mean, Mark was the one who spearheaded that, and he, Mark Swager, and he and all of us, of course, first and foremost, want to have clinicians, if they are to go into Google Scholar or, just Google kratom, have some alternative other than WebMD or the Mayo Clinic. Beyond that, of just raising awareness, I think there's the hope that we have that, and again, I have a clinical background, so I was actually initially going to go provide substance use disorder treatment to people. That was what I thought I was going to do in life. And clearly things have changed quite a lot, but I am trained to assess people with a DSM-5 and diagnose people. And what I know to be true, both on the giving and receiving end of treatment, whether it's substance use disorder treatment, psychiatric health, physical health, a lot of the patient-provider dynamics are asymmetrical. So you have this person with a lot of knowledge and authority and, quite frankly, a lot of power over you as a patient. And what really should be happening is this what is called evidence-based practice or evidence-based medicine. And it's this process, right? And as part of that process, the physician or the clinician is supposed to not only look at the available evidence for any sort of intervention or therapy or treatment or clinical decision-making, but also to take into account the patient's preferences, values, desires, perspective, point of view. And so it's really, I think, challenging in America, which has a very difficult system to interact with anyway for healthcare, assuming you can get healthcare and treatment. It's hard even for patients who are very privileged and able, or feel as though they're able to advocate for themselves and who feel empowered enough to maybe push back, not in a mean way, but just in a, advocating for your own clinical needs. Because at the end of the day, your body and your health and your everyday life better than the doctor does on some level. Now, I'm not saying how a cancer is spreading, per se, but how you feel, and more or less what you want your quality of life to look like. And that does need to be communicated to and received by the clinician. So we, at the end of the paper, wrote these tips for, if you're a clinician, here's who might be more likely to be using kratom, because we know a lot of the factors of comorbidities or chronic pain or fatigue. I mean, all these different things. But even among healthy people, who use it for recreation, that's also possible. But approach the person in a non-judgmental way, in a non-stigmatizing way. When you ask about kratom use, include it as part of a standard assessment. Don't make it this special, unique thing, but do what you should be doing, I would say anyway, which is to ask about any sort of supplement, over the counter, herbal, illicit, licit, every, the entire package. So it's not just Kratom, it's Kratom plus all the other things the person could be taking, and don't single it out as just this one thing, but do mention it, because your earlier point, I'm not sure if I were taking Kratom, whether I would tell my doctor about it for the reasons that your interlocutor said, but also I would want people to tell their clinic. It's this horrible feeling to have, because I would never say, oh, don't withhold information from a clinician, but at the same time, I do. I mean, we talked about this on the show last time, and it's, again, not a secret. I have a history of IV heroin use, and literally just this past week, I wrote a piece from the perspective of a patient with a drug use history to physicians about how I would wish that they would interact with people like myself. And I am in a very decent position from having been trained to be where I am now, that I can interact with a healthcare provider in a fairly savvy way. But the average person is not equipped to exercise their autonomy and advocate for themselves in a way that I think might be needed. And so it is a very, 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 very unfortunate space to be in, where I wouldn't know. I don't think that we could recommend I'm specifically not recommending anything one way or another, because it's up to everyone individually on a case-by-case basis. Because if your doctor's like a really good human and really listens to you and wants to understand, then yes, I mean, why wouldn't you tell them? But once it's in your medical chart, it's in your medical chart. And that is a decision that every person has to make for themselves. But I would say, if you're experiencing health problems, you should probably be as forthcoming as you can with your doctor.
Definitely. In that situation, definitely. So I talked to you last summer, and it looks like a lot of the research is showing kind of what people were reporting online. I mean, we've even done, it wasn't a survey, it was just, I just collected all our comments and hashtagged them, and based on first-person user experience. Are you finding out anything new, or any new nuances? We see that people use Kratom for either chronic pain, for self-treating opioid withdrawal, or for anxiety, depression. Is there any data that's coming out that either contradicts that or adds anything different to it as you find out more and more?
So nothing that contradicts it. I think what we're seeing is that, and the name of the name might have changed. I think the editors wanted a different name than I gave it, but the motivations paper that's coming out, I mean, we found over 40 unique motivations for using Kratom, and a lot of them fell within the self-treatment narrative, is what I call it, because that self-treatment narrative has really defined Kratom use in the United States since Ed Boyer, first wrote up a Kratom paper in 2007. I'm not saying Kratom was not used in the United States before then, because people have yelled at me when I've said that. I'm just saying that when we first started to have it on our radar between then and now, it's been defined largely by that. But a lot of people, I think what we're seeing more is the increase in recreational use, the increase in use for the nootropics. I always used to pronounce it nootropics. Then David Epstein, my mentor, was like, that's not how it's pronounced. And I'm like, oh, I feel like an idiot. So no, but people call it newts, or, but
we don't know how to pronounce anything in the Kratom world.
I don't either.
I mean the Kratom world.
How to pronounce it. I still can't say Kratom or Kratom. I'm horrible. But so, there's this subgroup of people who are really into nootropics, or psychedelics, and they're much more, I don't want to call them the psychonauts proper, but they're in the Venn diagram, they overlap with that a bit, but research chemicals, stuff like that. So there's more, I think, use for that, but it's broader than that, right? So it's this cognitive enhancing and also energy enhancing motivation. And this goes to people who don't necessarily have other specified that we know of reasons for using it, but it falls into more the recreational or energy enhancing, cognitive enhancing. I'm taking it for that combo of stimulatory slash analgesics. It's just uncanny how people describe it, even when we don't ask about it. But, it's like this kind of combination of just feeling good and feeling more alert, but also using it for relaxation as well. So I think that this entire range of use I would say falls under the umbrella of recreation and also just general quality of life use. And when I say that, I mean use that's more geared around things like coffee, almost like people are talking about it like how I talk about when I drink coffee or alcohol. I'm not equating Kratom to coffee or alcohol, although some people do, or opioids, as some people do. I'm not saying from a pharmacological standpoint. However, I am saying from a subjective and or intention to use standpoint, they're kind of approaching it in this more, not pragmatic, but very specific. I use it when I do this, or I use it before I do this, but it's not for self-treatment. And, but then again, we do see things like just greater specificity of the reasons for use, like IBS or chronic fatigue syndrome, and things that are very, very, very specific, in addition to just, I use it to enhance the quality of my life. And I think I said this last time, because maybe I'd already looked at the data a little bit, but everyone that we asked on the survey to check off a list of, what motivations they had, everybody but one person checked off multiple motivations. That makes sense to me, because most people don't use one thing for just one reason. It's totally possible. And I'm sure there are people who do, but I think people probably have like their primary motivation. And that's what we're going to find out with this next study is, proximal, real-time, momentary motivations. But then also we ask at the end of the day, what is your number one reason that you use today? And it was probably going to be similar across days, but maybe not for everyone. So that's something we hope to find out more and to see how dynamic that is.
I had a lot of questions about this assessment of Kratom use disorder. It was published in February, and I always refer to Nida's definition of addiction versus dependence, but what would you say like the difference would be between Kratom dependence and Kratom use disorder?
Yes, that's a great question. And, we don't even have to talk about Kratom specifically. This could apply to any substance. So the difference between, there's two ways to look at this. There's some people define addiction proper as a chronic disease or something like this. But so there's addiction and dependence in this really crude, broad way of just saying, someone's addicted to something and they have, usually what is associated with that is continued use despite adverse consequences, and usually continued use despite a desire to stop. So that's a very rough definition of what most people would say, okay, that's addiction. People are using despite continued adverse consequences and a desire to stop in some cases. And dependence means that someone has typically physiologically, they're dependent, defined by tolerance. So needing more and more of the substance to achieve the same or the desired effect, and withdraw, meaning that if you don't, clearly we know what it is, we all know what withdrawal is, but it's just, if you don't use it, you will start to feel symptoms specific to that drug class that are associated with that specific kind of withdrawal. So the very short version of defining what dependence is tolerance and withdrawal. And a lot of people use tolerance, withdrawal, dependence interchangeably, but they're not the same thing. And dependence really is when you take tolerance and withdrawal and smush them together. That's the definition. And as far as substance use disorder, that's technically a separate thing. So that is what is defined by the Diagnostic and Statistical Manual, which is the American Psychiatric Association's public. It's like the Bible of the APA. Yeah. Most people know what that is, and it's not the same thing as other assessments. So there's multiple other assessments floating around for how to diagnose problematic substance use. This is one of the main ones, but it's not the only one. There's a long history with other versions of the DSM, but this version, built into it, there are withdrawal and tolerance elements as far as the symptoms go, but then there are these other symptoms that are characteristic of psychosocial impairments or impairments in occupational functioning, or use when it is risky and is causing problems, unsuccessful quit attempts, craving. So there's actually 11, when you parse it out, there's like actually technically 13 different items on this checklist. And so if you're going to assess someone as having a substance use disorder, they would need to meet 2 to 3 to have mild, 4 to 5 for moderate, and then 5 or more is severe. You're defined as in remission if you have a 12-month period in which none of these are manifesting or you don't meet diagnostic criteria.
Okay.
So that is the checklist we used in our survey to assess. And it's also what Al Garcia Romeo used in his survey.
Of the people who were classified as kratom use disorder severity, it was 14% mild, 7% moderate, and 8.5% severe. I'll just read the quote. 8.5% of respondents reported having repeatedly used kratom in situations where it was physically hazardous. 10% endorsed the symptom, gave up or reduced some important social, occupational, recreational activities. 9.3% reported that kratom use repeatedly interfere with my major work, school, at home. You're just talking about that. So many people who use kratom, like me and my wife, were very mild users, and even people who are daily users, like, cannot believe that that's possible because of how mild kratom is. But you see this on Quitting Kratom, that people get into these situations. Is it always people who are taking large amounts of it that run into these situations where they're having like even psychological effects of withdrawal? I put it to every person who used to be addicted to opioids, like, are kratom withdrawals the same thing? And they always like pause and laugh or give me a funny response or be like, no, it's nothing compared to that. But it seems to be comparable to opioid withdrawals and like, these severe cases.
Yeah, there's a lot there. So this is this is among the most interesting things I'm thinking about these days. And I've been looking at a lot of these quitting kratom Reddit posts the last 2 weeks, actually, among other subreddit posts. But between anecdotes, case reports, our own survey data, other people's survey data, but our own in particular with respect to kratom use disorder, and then social media data, I think the short takeaway, and of course it's all preliminary, is that, and we see this with withdrawal too, not just substance. And of course withdrawal is part of the criteria for substance use disorder, but you don't have to have it to meet criteria. But when we assess withdrawal separately, what we see both with respect to substance use disorder criteria being met, and then also with respect to withdrawal, usually it's moderate symptoms, but there is a dose effect, at least with withdrawal relationship. So the more kratom you use for the longer, like more, the greater number of weeks on average is roughly associated with greater withdrawal symptom severity. So that relationship has been established very crudely because we don't have the statistical power. We had a very small sample, but nonetheless, we detected that relationship. And it's kind of like a no kidding. I mean, like we would expect to find the more you take of something for longer to be associated with a greater severity of withdrawal symptoms, for 1 day cessation or more is how we phrased it in one of the questions. What we see, and because I do want to make sure to articulate this before I speak about the dose and the withdrawal experiences that we've read about and coded, which is that for our kratom use disorder paper, when we looked at those individual symptoms, we see that the kratom use disorder was being driven more by withdrawal intolerance and less so by the psychosocial impairment. So even though we don't want to minimize those, from a clinical standpoint, I'm going to treat someone differently as a clinician if they come in here and say that they are missing their rent because they're spending all of their money on kratom and they can't go to work unless they take, like if they're doing some really problematic or maladaptive behaviors in order to keep using kratom, that's going to raise a lot of red flags for me than someone who's physically dependent on kratom, but otherwise functioning in all of the normative psychosocial ways that we would expect most people to kind of function on a daily basis. So I think that takeaway is a kind of a big one. And as far as the dose, I think this gets back to something you said earlier about like, you wish you could have something to tell your audience or people, who you interact with, what is like the one thing, to watch out for with Kratom. And I think in a way it's an unanswerable question because of the variability of Kratom products and how as well as I do, when we say Kratom, we could be talking about like 15 different things easily, probably, dozens at this point. And then there's variability with the leaves themselves, et cetera, et cetera.
It's almost like if we just discovered alcohol and we just call everything booze and don't differentiate between beer, wine, liquor.
Yes, that's a very good analogy. And so keeping that in mind, there's the additional complicating factor. So we don't know exactly what people are using different kinds of Kratom, meaning we can't give any recommendations or strong conclusions because there's so much variability. But the one thing I think that is safe to say there's two things that I think are fairly safe to say at this point. If you're using more and more and more of anything, in this case, Kratom, you are going to likely have some problems manifest as a result of that. If you're stable or just kind of fluctuating up and down or increasing a little bit, who's to say? But the thing that we are seeing over and over again in all of these quitting Kratom and other sources too, is that things start to go bad when two things happen. One, when the tolerance goes up and people don't manage it, but they just keep increasing their dose. So dose escalation, irrespective of product, but then adding onto that extracts. So I have to say, I am very concerned about the extracts that some people are using because it is for them. And again, this is like a fraction of people. So I'm not saying this applies to everyone, but a lot of the stories are like, yeah, so on and so forth, powder tea, blah, 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 blah. And then when I started using these extracts, and then you just see it go to hell in a handbasket, like really profoundly. And that's, again, not everybody, because some people are like, I treated myself to an extract on Friday and, the rest of the time they use whatever. But it's the relationship between either potentiation methods at-home extractions, extract products being purchased, and then increased dose. That's where people are having problems. And the last thing I'll add is that it's really, really, we haven't written this paper yet, and we're actually thinking about how we're going to do it now. And we invited Chris and Oliver on this one because Christopher McCurdy and Oliver Grenman, because they are chemists, and we saw a lot of like this kind of at-home do-it-yourself science this time around with Reddit, because people specifically are trying to achieve these really potent highs with at-home extractions. And
so they are doing that. They are doing
some
that
people
now.
Are not.
Okay.
Yeah. Some people are. I'm not saying most people. Most people aren't chemists. I couldn't do that. I mean, I'm not good at. I'm not that kind of scientist. Chris could probably do it. I can't do it. And so, but that's a minority of people. But then we have another group of people who are just purchasing extracts, and we see the problematic use. But here's the kicker, right? And this is what is very challenging from a clinical standpoint, not just a research standpoint, which is that whatever substance a person comes to use, doesn't matter what it is, they're coming to that substance and that relationship with the substance with their entire history behind them, right? So their developmental history, their prior drug use history, their emotional state. So if someone has psychological problems before they ever use Kratom, well, how much it goes back to the causality. How much can we say this particular nest of problems is the result of Kratom use? Or maybe they're taking too much Kratom because they had these problems to begin with. Maybe and I'm not saying this in a judgmental way, I'm saying perhaps if they didn't have certain characteristics that we know to be associated with problematic substance use, doesn't matter what substance, we know certain characteristics, they increase the odds of developing a substance use disorder. Maybe they have these characteristics prior to them developing a problematic relationship with Kratom. I have no idea because clearly we don't have that information. I mean, I would say Reddit data is no better than case report data in some way. There's more of it, there's more detail, but you still don't know the full story. And that's frustrating.
Do you find that people like in those Reddit data where you can't ask specific questions. Do you find that a lot of them are reporting that they had addiction when they really mean dependence, and they're just kind of freaking out about the fact that they have tolerance of withdrawal? Is that kind of a factor? And kind of skewing it. And then I guess another question would be, in your other report, using the Amazon, what was that?
Mechanical Turk.
Yeah, using that, you were able to find people that had discontinued their Kratom use, and so they don't have as favorable a view of Kratom. Are you continuing to look for those types of people?
So Amazon Mechanical Turk was used in identifying people who had who had ever used Kratom, and then we recontacted a portion of them for these smaller surveys, the ones that we've been talking about that are coming out. And the takeaway was not that they had less favorable attitudes, but rather that because we didn't have like a AKA promoted, regular Kratom users only survey, that we had a more diverse sample. So what's interesting is that even though it was about 43% considered themselves to be regular current Kratom users, and most people had used Kratom regularly at one point in time, and some had discontinued use completely, and some only used intermittently, but they weren't like this every day or every 4 or 5 days, user. Like they were all over the place, which just was really great. But even with all that diversity, including people who had quit, there were still actually favorable attitudes. Like most people still thought it should be legal. Like even the people who didn't use it anymore, but who had once used it, not everyone. I would say about a third of the sample thought that Kratom had become problematic for them or was habit forming or addictive. So a third is not nothing, but you have as many, if not more people saying it's been medicinal. Actually, more people were saying it was medicinal or therapeutic or helpful for them in some way. So it was all over the place, meaning it shouldn't be surprising that people have different experiences and come away. But it wasn't uniformly negative, even among people who had quit. So I think the quitting Kratom Reddit posts are also kind of, and I've read all the other subreddits too, so it's not just that, but I think they do skew a little bit more negative. When people write, they're not writing from this technical standpoint of a clinician. So what we do when we code is actually code, this means like tolerance, withdraw, and then professed addiction. So if they themselves say, I was hooked or I was addicted to, or, what either they perceived to be addiction or what is clearly being represented as, my life went to hell because of this. Like people were saying like this insidious weed and like, or plant or like all this stuff. Like, so some people had very clear conceptualizations of addiction, and other people talked about tolerance and withdrawal, but they didn't necessarily talk about addiction, or they didn't even and this is not just quitting Kratom. This is just on all of the subreddits. Like they would talk about tolerance and withdrawal, but not necessarily within the context of addiction. Yeah. So I think people can separate out different experiences.
I mean, on Reddit and specifically, like there's a lot of political motivations around Kratom. Have you seen that some of the answers that you got in the Reddit data were like from bots or people maybe faking one way or the other, writing a bunch of fake posts about it's great or it's terrible? Because I've talked to the bots of our Kratom, the mods of our Kratom, and they said some of the rules that seem a little overbearing, like you can't call Kratom an opioid, came from a response to another person coming in and trying to recruit people for what they suspected was a for-profit rehab. This is all like, but they have like certain motivations for why it's not just to make Kratom look good. It's just, it's to keep out like other political. But did you run into that in collecting that data at all?
We ran into Kratom advocacy, Kratom policy talk, things about like the World Health Organization were more, of course, that's a more recent thing that wasn't around a few years ago, because who had all of their discussions on what to do with Kratom. And so FDA, World Health Organization came up, DA a little bit, and then just state level things like or here, like, go advocate. So there was some very specific kratom advocacy going on, more so than we saw last time we looked. But as far as how we sample, so we
but what I meant was like fake posts trying to make kratom look good or bad.
So we cannot detect bots.
Yeah.
Personally, we can only, what we do remove are trolls. So there are clearly posts that are trolls, and we basically don't code them, and we just say this, X amount were removed from the final sample because they were not legitimate posts. And so we can identify those. But if a person is writing with a motivation, and it's not evident, like we can't necessarily know that. Clearly sometimes we know when people are like joking and stuff like that. But if someone has a motivation, we can only code based on what we see. And unless we have reason to suspect that it is, everything's motivated by something, but there definitely seems to be this like back and forth between, or the skepticism among people who haven't developed any problems with kratom. Are the people who are describing these experiences sincere? Because it seems really, really overblown. I think some people are surprised at how problematic kratom has become for some people. And there's been a little skepticism on that. It's like kind of meta discourse. We can't detect a bot per se.
This is from the Associations of Lifetime Non-Medical Opioid, Meth, and Kratom Use within the... this is from last November. Here, I'll just read the quote. Compared to those in the NMO-only group, the NMO plus Kratom group was more likely to report past year serious mental illness, suicidality, past month psychological distress. The NMO, methamphetamine Kratom group was more likely to report past year SMI, past month distress, increased odds for drug-inject opioid withdrawal. I just wonder what that suggested about multi-drug use. Is there just a common sense answer that people in mental distress are trying different drugs to help them? Or on the other side of the coin, does multi-drug use lead to mental distress?
The short answer is both. That paper was kind of like frustrating. And in hindsight, I wish we had looked at alcohol or I had added alcohol or ran it with alcohol instead of methamphetamine, because I've seen a lot more people reporting use for withdrawing from alcohol or replacing alcohol than meth. Most people that use substances are polysubstance users, because even if people forget caffeine is a psychoactive drug, right? Like, it's a psychoactive substance. So nicotine, caffeine, alcohol, all these different things, most people are polysubstance users. And, so Justin Strickland and myself came by way of University of Kentucky, and Jeff Rogers came from Arkansas. So we all came up here, and we're like, why is nobody doing meth here? And like, because where we came from, like, there was a lot of methamphetamine, there was a lot of cocaine use as well, but there was more meth. And here, where we live, there's a lot more cocaine and less methamphetamine, unless you like get out into the sticks more. And so we're used to this opioid methamphetamine combination that appears among a lot of polysubstance users, in some areas more than others. And we were interested to see, in particular, because kratom can have stimulatory effects, right? Like, people use it for fatigue and other reasons to kind of, energy boosting and enhancing their physical performance and stuff like that. So we were kind of interested to see how many people were using both non-medically prescribed opioids and methamphetamine and kratom. And to answer your question, it goes both ways. So people who are using multiple substances, and oh man, someone on Twitter gave me I've only had 2 mean-ish comments directed at me at Twitter. I've had a very lovely Twitter experience. No one's been too mean to me on Twitter. But one person was like, I forget what I'm assuming it was he said about the paper, but he's like, you could have found this with anything. And you know what? He's not wrong. Like,
I'm surprised you only got one so far.
I got one mean comment about, they thought I was like pro kratom. I'm like not pro or anti anything. When you put into a statistical model different variables, you're going to get a different output. So the things will change when you add other drugs, and they're not going to be the exact. So it's disingenuous to say that if we substituted kratom with alcohol, it would come out exactly like it did. That's not true. But the conclusions that we can draw from that is that people who have unmet mental health needs are using kratom and methamphetamine. And we don't know if it's because of the polydrug use that they have these other like mental health problems and increased risk of suicidality and things like that. If that's driving the mental health problems, or if the mental health problems are driving the polydrug use. In reality, what we often see, without fail, is that it's a circle. It's like this big feedback loop where if you're doing enough drugs and you have some mental health problems, it's going to be this kind of cycle, or it's going to be a self-feeding, self-perpetuating, one thing's exacerbating another. So I do think that, at least with non-medical opioid use and kratom, what we know for sure with those two are that people, not everybody, but many people are using them to non-medically self-treat a variety of things, including mental health conditions and opioid use disorder symptoms. Insofar as we know that to be the case, we can infer that maybe their unmet needs do have a relationship with the kratom use and the non-medical opioid use. Methamphetamine, maybe not. I mean, there are people who don't get treatment for ADHD or fatigue. Like there are people with chronic fatigue disorder who don't get amphetamine medications prescribed to them because they have a history of substance use disorder. So there's more work to be done. And Darshan Singh, he found, you briefly mentioned this in our email correspondence about what Darshan found in Malaysia, which is that there were people with heroin and amphetamine use disorders, or a history of problematic methamphetamine and heroin use, who were using kratom to kind of self-treat both. And at the end, and someone asked me this the other day, because they are more interested in the stimulant effects of kratom. And I said, we know that some people use it as like a stimulant substitute in some ways, and some people are using it as a study drug. I have people reporting that now as well. But we don't know if people are using kratom as a replacement, if they're polydrug users, if they're using it for a replacement for just one thing or many things. My feeling is that probably if they use a lot of things and they're trying not to use those things, kratom might be this kind of catch-all that just makes them feel less bad. Yeah. And they're taking it to just feel better in general. And
what have you found about kratom and cessation from alcohol use? It seemed like there was a good percentage of that in some of the surveys.
So we saw it in this last round of kratom Reddit coding. It came up more than I thought it would. And it came up, I don't have anything in front of me, and we've only started to actually do the quantitative analyses now, but it came up more than I thought it would, and certainly more than stimulants. But let me look here, because so it's not a majority of people, but so as a long-term substitute or replacement for alcohol, it was only 7.8% of the sample that said that they use kratom as a long-term substitute or replacement for alcohol. But when they rated that on a scale of effectiveness, with 0 being completely ineffectual and 100 being extremely effective, they rated it on average as 75.8, which is what I would consider to be moderately effective. Yeah. Fairly highly. I mean, because some of these effectiveness ratings were not that high. And then to relieve alcohol withdrawal symptoms, only 6.2% reported that, but the effectiveness rate was 72.1%. So for a short-term replacement for alcohol, so there were more people who reported that. So 18.6% of respondents reported using kratom as a short-term substitute or replacement for alcohol, which sounds kind of like what you were doing. And then with that, though, they actually rated it somewhat less effective at 66.3% on average, so 66 out of 100. So I would say that's a judgment call. I wouldn't say it was moderately effective, but it was somewhat effective. But it's interesting that the longer term was rated as more effective. I kind of thought it would be the opposite.
Yeah, it's not the same thing, and I don't even think it's the same collection of brain receptors based on what they found so far, because I guess alcohol is more GABA, but the whole thing with the opioid receptors, whether or not kratom's a gateway drug into heroin, is that occurring, or is it possible like a gateway drug into opioids? Like you have, I have these opioid effects with this kratom, they're mild, maybe real opioids would be better. Is that occurring?
Yeah, so it's something that we have gotten some reviewers earlier on when it was probably in like 2018. Someone was like, well, how do you know that people are using? So first of all, we know because people have literally said, I'm using Kratom to get off of heroin. So in those cases, I think it's pretty crass to say we should just not believe that people did heroin first and are using Kratom after that. That seems like a no-brainer situation. But in terms of overall, right? So we have no way of knowing if there's a person out there right now using Kratom and they've never used anything that acts on opioid receptors. So that's to say they're opioid naive. So if there's an opioid naive person out there trying Kratom, it is entirely possible. I don't have that information because I clearly don't know everything that's happening in the world, unfortunately. But I do think that there's two things. One, at least right now, most people using Kratom skew a little bit older. And what we looked at on this last survey was what we asked people, name every drug you've ever done in your whole life. What age did you do it? Have you done it in the last year? Have you done it in the last month? And so with Kratom, the average age of use initiation was about 30 years old. It was 29.9. To give you some perspective, the average age for alcohol, nicotine, cannabis was around 15, 16 years old on average. Yeah, now, what we see is, so what we see is Kratom looks a lot more like CBD and electronic cigarettes, like medical cannabis, and then buprenorphine. So what do all these things have in common? These things were not around forever. Like when I was younger, I didn't do buprenorphine or even have access to it like when I needed it, probably because it was not around yet.
They all sound like more boring versions of the stuff you use when you're younger.
Yeah, well, yeah, I mean, but they're new, right? And
like so what nicotine patch versus a cigarette, you know.
Yeah. And so what I do think what's gonna happen is that as CBD, as you know, and e-cigarettes are a great example of like the age of use initiation, like going down. So like younger people are starting because they've been around longer now. So I think as Kratom is around longer, I would predict that honestly, you know, this, because it would be kind of strange if this were true for like every drug except Kratom, or substance except Kratom. I think that the longer anything is available and around, the average age of use initiation for any group, and again, we're talking about on average for a large group, is going to be dragged down because it will just be around for younger people to try, whereas it wasn't around. So like, who was using Kratom first? Older people, not like old people necessarily, but like, you know, on average, older people. And so now that, especially if it's being used for recreation more as opposed to just self-treatment, I think we will see the average age come down. Now, with respect to the chicken and egg part of like, well, is that going to mean that it's a gateway drug for heroin? I don't know. And I think that time has proven that just because someone uses drug A or substance A does not mean that they will use substance B. Yeah. I think it's a highly, highly individualized thing. There are many people who are prescribed prescription opioids who then got on heroin. And there are many people who are prescribed opioids who have never, ever seen heroin.
Yeah.
And so it's going to be a very, very mixed case. And here, you know, we saw that basically every single opioid was initiated at a younger age on average than Kratom was, meaning that it's possible. I mean, I could look at each case individually. It's possible that like one person used Kratom before they used heroin, but on average, that is not what we're seeing. Now, that doesn't mean it'll always be the case, but it kind of goes back to, I think, some of what we talked about last time, which are use intentions. If you're looking for a heroin experience, or what is now going to be a fentanyl heroin experience, that is not the same thing as a Kratom experience. And honestly, fentanyl is way cheaper. If people are looking for that, they can probably find it much cheaper than they can find Kratom.
And we're not advertising that.
No. And I also want to say something in all seriousness that came up. And because this really does this frustrates me, which is when people, and again, it's not most people, but a lot of people on Reddit who've started to use Kratom and then had a bad experience with it and have gone to like quit Kratom eventually or attempted to quit, they're really, really pissed off, understandably so, because when they started to use Kratom, and like part of this is, I'm not saying it's on them, but it kind of is like they didn't do their homework, they didn't research it thoroughly. But at the same time, they believed the person or the vendor or the dude at the gas station who was like, oh, it's like coffee, but it's not coffee.
Yeah.
Like that's really not good. Like that's not an accurate representation of what you're advertising and what is actually pharmacologically, if there's metragine in the product, going to happen. And like, so I do think that it's incumbent upon consumers to really understand, like with anything, what it is they are choosing to put in their body or not put in their body. But when people are like, after the fact, finding out, oh, well, this acts on opioid receptors, in addition to many, 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 serotonin, dopamine, adrenergic, it acts on many receptors.
Yeah.
The industry has to do something about, because it's not a good look for them. And I can't do anything about it because it's not my job.
I got a last question here.
Okay.
It was from the discussion from the Reddit study, but it says, for some, Kratom was life-saving, and for others it was ruinous, or yet another substance to which they had become beholden. Like other findings, the provisional takeaway is that it's premature to laud Kratom as a cure-all, and equally premature to demonize it as a dangerous substance with risks that outweigh benefits. So my question is, does it have to be one or the other? And can't we just look at this as a complex thing rather than what you're just talking about, vendors overselling it, or maybe like somebody who profits from rehabilitation to be demonizing it?
I'll just say yes to the first part of that, which is it is infinitely complex pharmacologically. There's 50 alkaloids that we know about. We are in the infancy of understanding it. And right now we have some preclinical work and we have the early stages of self-report work. And that's it. I mean, we have from a scientific standpoint, very little information. And so we have to default to what is the obvious truth, which is that it is complex as a plant, and the mechanisms of action of any one or multiple alkaloids are going to be complex, but then also people are complex, right? And everyone's situation with any substance, Kratom, anything else, is going to be unique to that person. That's not to say we can't say a few broad takeaways, like I said earlier. If you're using a high amount of Kratom every day for a year and then you stop, you're going to probably experience some kind of withdrawal syndrome, whether it's mild, moderate, severe, I don't know, but you're going to feel a little different. And that's common sense too. Yeah. But yeah, it's really, really, really complex. And, you could map this on, I think the story of Kratom in the United States is really interesting, because you could look at cannabis or alcohol or heroin. You could look at so many different things and ask yourself, is this inherently bad or inherently good? And it's neither. It's neither. It's a substance, and people are people, and everyone is going to have to kind of make their own value judgments, and then the science will play out as it does.
Some of the people that have done Kratom, they'll say, okay, this is terrible. They blame the drug because once they quit the drug, their life got better. And so they say, this is what it does to you. This is what it does to you. This is what it does to you. Meanwhile, opiates have done nothing but help me. I never abused them when I got my wisdom teeth out or when I got surgery. They help me. It doesn't do that to you, and it becomes kind of like a preachy thing.
I've seen exactly what you're talking about, but I've also seen there are people with a good amount of self-awareness who have said there were other things going on with me, and this is like one of many things I need to work on. So like Absolutely. You kind of have that finger pointing and like blaming what is at the end of the day a plant and I will say, I do think it's fair to blame certain industry players. The plant is the plant, the industry and advertising, and that is its own thing. But then other people are like, you know what? I had a lot of stuff going on. I already had a history of addiction, and I had a lot of issues emotionally happening, and I was relying on this. And also COVID was really, this time around, we saw COVID impacting people, and like
Definitely.
people were taking it like a lot more because of like they just weren't having to go to work and stuff. And they were like, these conditions all culminated to result in this addiction, but they didn't blame Kratom. They blamed all of these various factors. And I think that's closer to like reality.
Thank you, Dr. Kirsten Smith. I'll be posting that link out of the assessment as soon as she sends it to me. That'll be on Twitter. Follow us at Kratom Science. I'll also announce it on here. All the links to the studies we mentioned are in the description. Please share this on social media. Like, subscribe, rate, review, comment anywhere you listen to podcasts. The music is Risey. The song is Memories of Thailand. The Kratom Science podcast is produced by me, Brian Gallagher, for KratomScience.com. Take care.